The landscape for treating MS is going to change dramatically over the next several years. We're already in the process. We have our existing agents, the injectable agents, interferon beta and glatiramer acetate, which I suspect will continue to be used for some time because we have a lot of experience with them. They're very safe and they work. However, we have some unmet needs. First unmet need is we'd like to have a pill. We have pills in the pipeline. Second unmet need is that we like to have agents that are even more effective than what we have now. Again, in the pipeline, we have the promise, and even a trial or two that now show agents with better efficacy. The other side of the issue will be assessing the safety and the risk. That's a little harder to do based on the evidence we have now, but we do have 2 agents that have completed phase 3 studies with some safety questions, but at the doses they're moving forward, maybe not as much concern as we once had. But it's still early, and we need to see how they play out once and if they get into the marketplace. The next agent to come along will be a pill that's being evaluated very soon, fingolimod. Very good efficacy, even good comparative efficacy compared to interferon beta 1A given once weekly. Safety profile needs to be looked at more carefully, and we'll see how the FDA handles that. Several more pills in the pipeline. Some also look to have very good efficacy, but some questions about safety. Others, perhaps not quite the same efficacy, but at least on initial testing, maybe better safety profiles. In addition, we have monoclonal antibodies, the one already on the market, natalizumab, which has very good efficacy but does have a safety concern. We have other monoclonals that will be coming along, things like alemtuzumab and daclizumab are being tested, and they hold the promise of better efficacy, especially alemtuzumab from its phase 2 data, but again, a more challenged safety profile. In the end, the decision-making process for the clinician will be enhanced by having more choices, but it will also be a little more difficult to assess because figuring out risk-benefit ratio is not easy. But we don't yet have the metrics to determine for an individual patient what their course is going to be. I'd like to say that I could tell when someone first comes to see me early in the course of their disease that you're going to do great, we could treat you with a very safe agent. You're going to do very badly, we need to treat you much more aggressively. We don't know how to do that yet. I suspect that those assessments will be coming along over the next several years as we better incorporate the clinical picture, the MRI picture, including advanced MRI metrics, and biomarkers. But we're not there yet. So the outlook right now is a broader therapeutic spectrum of agents that we can treat with, but more challenges in figuring out who's appropriate for which agent and how to best judge the risk-benefit ratio.